Dr. Carla Lester with Teach a Kid to Fish and the NMA's Childhood Obesity Prevention Project, Holly Dingman with the Department of Health and Human Services Nutrition and Activity for Health Programs, Dr. Christina Fernandez with the HEROES program at Children's Hospital and Medical Center, Dr. Sally O'Neill, Jeff Klein, and the staff at Creighton University CME, and Dr. Courtney Pinard from the Gretchen Swanson Center for Nutrition for the work they've done to make this webinar possible. I'd like to introduce Dr. Carla Lester, who will talk about the CMA credits associated with this webinar and will give the background of the Foster Healthy Weight and Use model. Dr. Lester is a pediatrician here in Lincoln that started a nonprofit organization called Teach a Kid to Fish. Its mission is to prevent and reduce childhood obesity by empowering Lincoln children and families to eat healthy and be active. Dr. Lester also developed the NMA's Childhood Obesity Prevention Project. Dr. Lester?
Thank you, Gina. And I just kind of want to go back and say the topic of today's is obesity, hunger, and poverty. Just remind you, I'm going to go through some logistical information and then talk a little bit about Foster Healthy Weight and Use, those clinical resources prior to introducing our speaker today. Welcome to the webinar and thank you for joining us. The Creighton University School of Medicine designates this live activity for a maximum of 1 AMA Category 1 credit. The information in this training has been approved for 1 continuing education credit hour by the American Medical Association, Creighton University Health Sciences, Continuing Education, and the Commission on Dietetic Registration. A detailed information sheet containing this information accompanies this webinar registration and may be found on the Creighton website. This activity has been planned and implemented by a lot of partners, including Creighton University Health Sciences, Continuing Education, the NMA, Teach a Kid to Fish, and the Nebraska Department of Health and Human Services. Neither the planning committee or speakers for the webinar series have any conflicts of interest or disclosures and have signed statements that they may be such. After the webinar, you will be sent a link to the post-test and evaluation via email, and you may also visit cme.creighton.edu for more information. Let me tell you a little bit about Foster Healthy Weight and Use. This is Nebraska's clinical childhood obesity model. These are clinical resources which have been and continue to be disseminated to physicians across Nebraska. It is a comprehensive model with a toolkit, pocket reference algorithm, free CME training video, which outlines the steps in assessment, prevention, and treatment in the primary care setting. There are also consistent messaging, patient brochures, and posters to resource your offices with. All of the resources are free and are available through the NMA's website. Today's webinar is titled Obesity, Hunger, and Poverty. Our speaker is Dr. Courtney Pinard from the Gretchen Swanson Center for Nutrition. Dr. Pinard is a research scientist at Gretchen Swanson Center for Nutrition and also holds an appointment as assistant professor in the College of Public Health with the University of Nebraska Medical Center. Dr. Pinard's research focuses on program policy and environmental approaches to health promotion and reduction of health disparities in the following ways: childhood obesity prevention, the relationship between food insecurity, food systems, and food access, and the public health impact of local food systems. And with that, I'm happy to turn the webinar over to you, Dr. Pinard. Thank you.
All right, thank you for that introduction and for having me on the webinar today and for all of you listening in. So I work with a nonprofit nutrition research center, as was mentioned, and we're based in Omaha, and we focus on 4 main areas: childhood obesity prevention, food insecurity, local food systems and health, and an overarching emphasis in survey development and evaluation. So feel free, if you're interested in these areas, to follow us on Twitter or Facebook, because we try and disseminate useful information. So a little brief agenda here. I do have a lot of slides to get through, so you'll find I might be skimming over some. I wanted to include more just to give you some more information. And so briefly, I will be touching on childhood obesity, food insecurity, and poverty, and then how these issues overlap, especially within the context of the food system. So I think this group knows the issue of increasing rates of childhood obesity, so I won't belabor the point, but we have seen a dramatic increase over the past 30 years. So state by state, we see that Nebraska sits pretty much in the middle, around 24th place on a national level, and on a national level, there are about a third of the children are overweight or obese, and this really increases This really is increased in our African American and Hispanic populations to 40%. So this is a summary of the causes of childhood obesity. Genetics and certain drugs can account for some weight gain, but mostly we look to energy imbalance, and the lack of fruits and vegetables and increasing reliance on processed food is one issue, as well as sugar-sweetened beverages, and then coupled with a lack of physical activity, which seems to be replaced by screen time in our youth. There are a number of socio-cultural factors as well, and this really relates to the home environment and income level and a number of other factors. Just a brief overview of what types of causes might exist. The consequences of childhood obesity, which I am sure you're aware of, include children being diagnosed with conditions that were previously only seen in adults, such as type 2 diabetes, which used to be called adult onset diabetes. And just shockingly, this is the first generation of kids that are predicted to not outlive their parents. So this comic really kind of speaks to some of the causes of childhood obesity. He says, the parent says, "Devin, we've been telling you for years, eat your vegetables or the vegetable police will get you." You thought this was all a big joke. So how did we get here? We currently live in an environment that is what we call obesogenic, and this is where this sort of depicts the average person working hard to overcome an environment that is full of oversized portions, processed foods, and a lack of physical activity options. So this really speaks to the need to make the healthy choice the easy choice or even the default choice, which it currently is not, as I said, the obesogenic environment. So further describing this environment, we see increased availability of processed foods, and our diet has really shifted from fruits and vegetables and whole grains to one that really relies on processed foods, snacks, condiments, which sounds odd, but that goes along with a lot of the fast food, heavy reliance on cheese, and meals eaten away from home. And this can really go back to, which I'll try and tie into the end of the webinar, the shift towards reliance on commodity crops and away from fruits and vegetables. And then as far as physical activity, you know, children today don't have as much freedom, and due to real and perceived notions of unsafe neighborhoods and reliance on our cars and due to urban sprawl, and you know, as we see, sedentary jobs are even more highly rewarded. So this piece, Newsweek went to Europe and bought the same item. Oh, I don't know if that showed up on your screen there. Went to Europe and bought the same item as in the U.S., and in every instance they saw that the U.S. item was a larger portion. So for example, the cappuccino in Naples, Italy was 40 calories, and the small at Starbucks was 140 calories. So just showing that restaurants don't always have our best interests in mind. So we know that a number of groups are at higher risk for obesity, including those with low access to physical activity options, so you know, streets that aren't connected with sidewalks that are safe, and those with lower levels of education, those with lower income levels, and also living in, on the bottom right, what we might consider a food desert, and racial and ethnic minority groups. So just a depiction of food cycling, something that might sort of help explain how childhood obesity occurs in low-income families more often. We see that perhaps resources for food stamps or SNAP last maybe the first 3 weeks of the month, and in that last week they're experiencing hunger. When access is restored, the tendency might be to overeat on rich foods, which really deregulates hormonal responses to eating, and satiety, creating stronger urges to overeat. And then the overeating on rich and you know, cheap foods, as I call them, really relate to the cost of healthful eating. And this is shown here, where we see that the average price per serving of different types of foods, and processed foods in blue, for instance, tend to be cheap and calorie dense, and fruits and vegetables tend to be a little bit more expensive. So these next two slides sort of summarize from CDC, the Centers for Disease Control and Prevention, what are the current areas that they're focusing on. So just to give you a smattering of types of things that are currently being addressed to try and reverse the trend of childhood obesity is something like menu labeling, for instance, and the point of decision information, and that's going on in a number of communities across the nation. And increasing fruits and vegetables is always an avenue, and a lot of that comes in with farm to where you are, which I'll touch on with the food system later on. And then sugar-sweetened beverages, this was kind of a hot topic lately with the Mayor Bloomberg in New York, and really the argument is that this is the piece of evidence that we know exists. You know, strong connection to overweight and obesity is the consumption of sugar-sweetened beverages. So limiting access and providing water as an alternative is very strongly supported by the evidence. And also television viewing and increasing opportunities for physical activity and breastfeeding are always good avenues for childhood obesity prevention. So like I mentioned, the hot topics, so for each of the topics today, I just wanted to give you a quick, what is a current area of interest, both in terms of the media and, you know, the actual research evidence to go along with it. So pink slime came up recently, and it became a topic of interest because it was found to be included in the school lunches. The National School Lunch Program was purchasing large portions of it. And I mean, but in reality, the pink slime thing has been going on for over 20 years. You know, the idea of grinding up parts of the animal and fat and treating it with ammonia to sort of stretch the product further. But the bottom line is people don't want to see it in school lunches, and also just to label it so consumers can make the choice. And I think that's the argument, no matter which side you stand on, whether you're pro pink slime or against it. I think labeling is a key factor there. And with the soda, like I mentioned, it is the one thing that we know really linked to obesity. And I like Mark Bittman's argument. If you look up on the New York Times column, he defined soda as non-food, so it really does parallel the tobacco argument. And then we also can sort of go back to the healthcare costs associated with that. So just a few little tidbits there. Let's see. It's not moving. Hold on a second. All right, so this is an example where this tool is called the Family Nutrition and Physical Activity Survey. I just wanted to throw it out there as an option because it's something I used in my dissertation work, and I've seen it kind of evolve over the years into something where they have it online, and parents could potentially fill it out before their visit with the child, and then there is a score and different recommendations given. So I just think it's a potential there to sort of integrate into the current line of, you know, care given to our families. And so some of the key factors that this survey gets at are breakfast consumption, TV in the bedroom is a big one, things that we know that are strongly linked to childhood obesity, as well as you know, family mealtime and just hours of screen time and whether they're participating in physical activity. So pretty basic stuff, but then the key thing that comes out is this is just a screenshot of part of the response that is a PDF that could essentially be sent back to the pediatrician or whoever to be able to counsel on this further. So say the family indicated that they're not typically eating breakfast together, and so that then there is a recommended practice that, you know, this is an important component to prevent childhood obesity, and eating together really establishes a family interaction related to eating, socializing around that behavior. So that could be something implemented there. And then another resource, if you're looking for measurements on a number of different things, the NCORE registry is the National Collaborative on Childhood Obesity Research. And so this website has a lot of resources, but in particular I like this measures registry because it provides you know, validated surveys that people can pull up as needed. So you can, for instance, here, if you wanted to look at dietary behavior in 6 to 11-year-olds, you could compare all these surveys and see which one might be best for your setting. Oh, And so just really briefly here, once you look at a certain measure, you can really see how it's used, the reliability and validity, where you can get it, and things like that. So it's pretty useful. So now we'll move on to food insecurity and poverty. So basically, to be food secure, it's really defined as having access by all people at all times to sufficient food for an active and healthy lifestyle. And to be food insecure is the opposite of that, where you know, you can't obtain sufficient food in socially acceptable ways. And the USDA kind of further delineates this. The main way that we measure food insecurity, I'm going to preface this that there is a real limitation with this measurement, but it's pretty much what we have right now. And it classifies people into different levels of food security, from very low to high food security. And that I could do a whole nother webinar on the limitations of this measurement, but currently this is how we're measuring food insecurity, and the numbers really show that about 16% of U.S. households are food insecure. So these people could be our neighbors, and you know, we have this large portion of this large growing number of working poor in our country, and just looking around at the number of people starting to rely on emergency food systems and even SNAP is really unacceptable, where we have so many resources at our fingertips. So the 16%, especially the very low food secure at 5%, it's not something we think as a domestic issue, but really is. And we do have certain factors that are associated with higher levels of food insecurity, just like obesity. In particular, single female head of household is a large predictor, obviously poverty, and minority status. So some of the health consequences, which you may be familiar with, of food insecurity for children in particular, are undernutrition and you know, poor performance in school and physical outcomes, and mental health issues as well. And so just to show you the overlap, we've seen these maps of obesity and where the higher levels are. And then these same maps kind of exist for poverty levels in those same areas, and then food insecurity. So this comment kind of speaks to the link between poverty and obesity, and that it is expensive ultimately on our healthcare system. So this paper here, with the reference on the bottom, describes the food system and how people could essentially fall through the cracks. And people may have challenges accessing food and other barriers, and this really kind of summarized the different points at which people may become food insecure. And there is an initiative in the Omaha metro region, is Hunger Free Heartland. It's a tri-county initiative, and in their first year, the goal was to make sure that every child had access to a healthy breakfast. And these are some of the benefits and barriers to eating breakfast that children indicated. And so some of the positive things that we could promote that the youth tended to agree with are, you know, agreeing that breakfast is the most important meal of the day. And then some of the barriers that we can hopefully address are not thinking it's cool to eat at school, you know, the breakfast provided through the school lunch program, and not having access at home or not having time. So current areas of interest with food insecurity relate back to nutrition assistance participation. This is a big issue. We have underutilization of our SNAP program and WIC programs, as well promoting the free and reduced lunch enrollment. So that's something that we can, you know, promote in our patients and whatnot. And with the Farm Bill, there's a lot of issues coming out recently, since it's under review right now. And some of the issues that are key are moving some of the funds towards specialty crops, which I'll describe a bit later too. Are actually vegetables are known, are classified rather as specialty crops currently, and you know, the only subsidized crops are corn, soy, and wheat, and meat products. So this is an issue that the Farm Bill could help address obesity and and food insecurity as well. And it also includes some positive things that the new Farm Bill might include are promotion of farmers markets and reducing food aid dumping in developing markets, and then crop insurance and subsidy limits. And something that might not be addressed that should is labeling genetically modified foods. And the continuation of log rolling of SNAP into the Farm Bill, I think, is a key factor to keep that program alive and keep some of our hungry people accessing that program. And another issue is just the healthfulness of the foods in the emergency food system, in particular the food pantry. So I kind of call it the syndrome of the church ladies thinking that everybody deserves access to brownies. So if you've ever been to any of these feeding programs and seen the trays and upon trays of sweets that people are making, which is a nice thought, but really we need to look at what is being offered in these emergency food programs. So the intersect of obesity in general and hunger is something that we think of as a paradox and not necessarily going together, but hopefully we can tie it a bit together today with the food system. And so both of these factors really relate to malnutrition and comes down to poor dietary quality. And so the food system can range from more global to a more individual level. And the closer you get to the center of this figure, which is what we would consider a more sustainable food system. And inputs from inputs and through consumption, there are many points of entry from which we can make the food system more sustainable, but also promote healthier foods ending up on our plates. So some trends with the food system are that basically there is an increasing demand and growing interest in local and sustainable or community-based, however you want to call it, food systems. And we've seen that with the expansion of farmers markets. Today we have a huge increase, and we see them popping up all over the place, as well as an increase in smaller farmers. I don't know if you've heard the statistics that there's an aging farmer population, as well as the number of farms have dramatically decreased to where we're really relying on a fewer number of humongous operations, essentially. So it's good to see that trend reversing and smaller farms becoming more and more common. And some of the factors why we would like to have a more local and sustainable food system is the traceability of the food supply with food safety concerns and things that have come out like the listeria and the cantaloupe and whatnot. I think that's an important thing to consider, as well as just supporting the local economy, both from the food and beyond. And increasing the food security in our communities and instituting such programs as farm to school across public schools, as well as larger institutions, to where more local foods are being incorporated into cafeterias. And then community supported agriculture is another thing that's been on the rise as well, and that's where people can buy a share of a farm and receive foods throughout the season. So it's important to note that organizations like the American Public Health Association and the American Medical Association support further research on food systems, yet at the same time, this is because we have limited evidence to support the health link. Is local food more healthy? I mean, we have more anecdotal, and we've seen some limited evidence as far as increasing fruit and vegetable intake, but there really is no evidence to support that promoting local food is obesity prevention, even though we're working towards that currently. So this slide kind of summarizes the biological and behavioral mechanisms that relate to both hunger and obesity. So I've kind of gone through the episodic food shortages and food cycling, as well as availability and cost issues that really influence food choices. One issue that with the typical American diet has to do with choice and also what is available. So we see that the typical American diet is high in refined grains and meats and added fats and sugars. And what we're supposed to be eating as, you know, prescribed by my plate is half our plate fruits and vegetables, more whole grains, and smaller portions of meat and refined grains and dairy as well. So that kind of relates to cropland that fruit and vegetables are currently taking up in our country. You know, you see this small portion in the corner, and the rest of it being soy and corn for cattle, and both high fructose corn syrup and then wheat. Like I mentioned, those were the subsidized crops. So if we shifted, more of our local economies would benefit if we shifted to more fruit and vegetable production that was more community-based. And that would really have to come ultimately to make this successful from the top down. The current infrastructure doesn't really support or subsidize what fruits and vegetables. As I mentioned, they're considered specialty crops. So making them part of this investment as an obesity prevention effort. So the lack of availability of healthful foods impacts many Americans and what we call living in food deserts, and also like the term food swamps, because that really refers to the fact that there are options but they may not be the most healthy. And so just by definition, a food desert is a community that has a higher level of poverty but also low access. And so for urban areas, it's 1 mile to a grocery store, and then for more rural areas, it's 10 miles. So the food desert locator is put out by the USDA, and these are the regions in pink here in Omaha that are considered food deserts by definition. So we see the north and south Omaha and more eastern portions of the city experiencing the food desert problem. Another resource to look at communities, you can look at county by county, is the Food Environment Atlas. And so that looks at access to stores as well as utilization of programs like SNAP in the school lunch program and food security and health outcomes. So some current areas, as I mentioned, you know, farm to where you are programs are expanding, and that's also kind of terms know your farmer, know your food. And we've seen that really expanding to include more low-income populations with EBT or electronic benefit transfers at farmers market, and double up programs are, if you haven't heard of them, implemented in several communities where people are given vouchers, and it allows for their SNAP dollars to go further at the farmers market compared to grocery stores. And sustainable food systems can help also with our, obviously, improving our environment as far as reducing use of pesticides and even transportation of food, and labor equity issues. And then a lot of people refer to food sovereignty, and that's really talking about the community as a whole and their right to define what their food system is instead of having a global food system fed to them from the top down. And as I mentioned, we still have to work on the evidence part as obesity prevention. So educating kids about where their food comes from can be an avenue where I think we can promote a more healthful diet. So I kind of mentioned the reduction in farmers, and but also how do we overcome the advertising from big agribusiness where we see $5 of advertisements for every dollar of healthy food advertisement. I'm not saying we need to dump more money into promoting broccoli, but I think that that's something that we're working against, and it's part of that obesogenic environment that I described earlier. And so just a brief diagram to show, you know, what kids really think about food and where they have room to learn. You know, they think chicken is a dinosaur-shaped chicken nugget, but then they might learn that you can get a chicken breast from the grocery store but then that chicken breast comes from this animal that looks whole like that in the middle, and then that is actually a chicken walking on a farm, and this is the person who raises that chicken. And so just to go completely the other way, the increase in interest and demand for local foods, this woman has a cow in her kitchen and saying, "Mommy wants you to know where your food comes from." So with that, I think I'm finished describing these issues, and this kind of diagram here summarizes it, and I'm free to take any questions.
Thank you, Dr. Pinard. We'll now open up the webinar to any questions you might have. Again, you can type your question in under the chat or questions portion at the right of your screen, or you can press the raise your hand button and we will unmute your line.
You can just ask that first.
Yeah.
Yeah, I can answer that. Okay, you're on. Okay. Dr. Pinard, we have a question about the slides being available to print. Are you okay with making those available?
Sure. Yep. Feel free.
Okay. Great. And then we have another question, and that is, yeah.
You mentioned the healthfulness. You mentioned the healthfulness of food pantry offerings, but what about the healthfulness of SNAP purchases? Why is the SNAP focus only on expansion as opposed to directing funds to nutritious food?
Yeah, I think that is still a point of contention for a lot of people, whether it's taking away the choice of what people can purchase or pushing them towards more healthful options. And I think that is definitely something that needs to be addressed, and that we should promote, like the programs like the Double Up Bucks. Having the food dollar go further for healthier options, I think, is a really good avenue, and hopefully that would promote more healthful purchases for people. And that would really mean the government deciding that they wanted to subsidize more fruits and vegetables instead of calling them specialty crops and not supporting them.
Dr. Pinard, I had a question. This is Carla Lester. I was wondering, I had seen a study recently that talked about even if there was access to a grocery store in an underserved area, that it didn't have that much impact on those citizens making healthful food choices. And what I'm wondering is, it's kind of a two-sided question, is what's the issue? Is there any data out there about just food preferences? It's kind of more of a physiology question, that are we wired to, since we're wired to maybe want more fats, sugars, and that even if we have healthful food choices, it's not enough to overwhelm the other choices that are unhealthy?
Yeah, so I think the first part of your question is, just the appearance of a full-service grocery store in a community doesn't necessarily mean that people are accessing it and it helps address the problem. And so I think that from a food environment perspective, there's a lot of evidence showing that small grocery stores and even convenience stores having healthier options is an avenue that people will uptake, and that really speaks to what is culturally appropriate for that community and within their normal day-to-day life. So I think that we need to be creative and involve the communities themselves when coming up with solutions like that. But then to the other part of your question, food preferences are an issue. It's kind of the question of, if you build it, will they come? And I think that it is an issue that, nutrition education, and we need to continue our efforts at all levels of the socio-ecological model, where we're looking at individual level behaviors and preferences and educating and promoting on that level, as well as changing environment and policy to help support those decisions.
Okay. Thank you.
Does it look like we have any other questions?
Yeah, I'll ask a question. Dr. Pinar, this is Holly Dingman. Thank you for your great presentation. I have to go back and study your slides because there's so much good information in there. You mentioned the underutilization of WIC and SNAP programs. I'm wondering if there's a role to engage our healthcare providers in promoting their patients to enroll in WIC or SNAP, or have you seen any models out there? Or what recommendations do you have?
Well, I think the more we can connect, healthcare with our community resources like WIC and SNAP, that is an effective model, and it's more of like a systems approach. And I think that that's something that we could work on in Nebraska in particular. And given limited time that in a healthcare setting, I think that there needs to be kind of creative solutions. So maybe there's something like the screener that I showed, the family nutrition and physical activity survey, related to other issues too, so that it's more automated and that we can link these people up with the resources they needed and not necessarily put more pressure on providers, but somehow to have creative solutions that maybe involve technology.
That's a great idea. Because our toolkit includes the physical activity and nutrition assessment form, which is a paper carbon copy form, I really like the fact that your survey is online. I'm curious, because a lot of the questions are the same, how many questions are on there, and what's the length of time for families to go through that, and did you aim for a certain reading level?
Yeah, well, I wasn't involved with development of that, so just for FYI, that's Greg Welk at Iowa State is behind that survey, but I used it as sort of on my dissertation to help validate another survey. So it's kind of the purpose of that survey really gets at the obesogenic environment in the home, and it is about it's like one page front and back, and it would take someone less than 10 minutes, I think.
Okay, good.
And it's just getting at the key things that have a lot of evidence behind them being related to childhood obesity, like TV in the bedroom.
Yes, that's good, and that's exactly how we had originally structured our assessment too. But like I said, I like the format online. Having patients fill that out prior to even having their appointment, perhaps.
Yeah, they validated that survey, I think, a lot in the school setting, and they haven't yet integrated with a healthcare setting, and I think that's kind of the next phase for that. But I've seen that it came recently online, and I just filled it out, for myself just to see what the output was, and I thought that the counseling bit was a key factor, because sometimes you can have a healthcare provider look at, okay, what are the issues here, but then what do they tell them, what is the counseling, where do they refer them to, what's happening there. So I think that's where we can kind of enhance the system even more, is provide more points for counseling and even referral systems to other programs.
Right.
Okay, it doesn't look like we have any other questions. We'd just like to remind everyone there will be a link sent to you within the next hour for the link to go out to complete the evaluation and receive the 1.1 continuing education contact credit hour. That evaluation link there will be an evaluation, and then you'll need to print off the certificate yourself for your record. Also remind everyone of the Childhood Obesity Prevention Project. This is an initiative that Nebraska Medical Association, and all of the webinars are taped and posted on the website for 2 years that you can go back and view. And lastly, just to remind everyone about the Fostering Healthy Weight and Youth, all of the resources, models, and any anything you want to access, you can do a request form off the COPP website, or you can email Holly Dingman at the email address that's on your screen. With that will conclude today's webinar. Thank you for joining us.